Hi, Andrew Knight's my name. I'm here to talk to you about one of the projects that we're currently undertaking at the GP unit with some partners to do with the connection between general practice and cancer services in our region in southwest Sydney. So this is an important slide. It captures what I think is actually one of the most important parts of the project. As you can see, as with good quality improvement, it usually involves a number of partners. In this case, we've got an academic general practice unit, ours, which is part of the University of New South Wales. We've got the South West Sydney Local Health District Cancer Services, led by Jeff Delaney, and Jeff's leadership has been key to the general support of cancer services in this project. Afa Gurgis from the Ingham Institute, and particularly Cancer Translation Centre. And then, of course, really importantly, is the primary health care support from the Medicare Local, South West Sydney Medicare Local is part of it. And all of it has been resourced by the Cancer Institute of New South Wales. A little bit of money from them and a couple of grants has enabled us to do a project together. And I think almost as important as the content of the project has been the form of it, because it's been the start of a relationship between these four organisations to work on service improvement. We've been successful in getting grants for a couple of projects. In the first project, we talked to 22 GPs spread across the region, and I've reported on that before, and we did semi-structured interviews with them, looking specifically at what did they think it would take for them to be better integrated with cancer services. As qualitative work was very rich in terms of the data we got, but we've summarised it into three really key things. First of all, they're very positive about the cancer services, which was encouraging to our partners, that they thought cancer services, which has been working hard to do a good job, was good. But a couple of points that they thought would help. One is that they really felt that they didn't necessarily know cancer services. It was almost relational, that they wanted to know who's there and who the people were and the sorts of services that were available. And they wanted to be known as well, in a sense, have a sense of a collegial relationship with them. But they also pointed out that the letters they get from cancer services are not timely, and that was one area that they felt could really make a difference. So the second project that we applied for was particularly around those last 2 points, and particularly we're focusing on speeding up the letters that go to GPs from cancer services. So we wanted to produce them quicker, and we wanted to transmit them better. So if you've ever done any quality improvement, you know that there are three fundamental questions that you ask yourself when you're trying to improve something. First of all, you say, well, what are we trying to achieve? What is our aim? In this case, we set ourselves the aim of getting letters from the cancer specialist to the GP in a week. The second important improvement question is, how will we know the change is an improvement? That's a question about measurement. And in this case, we set ourselves, we're fortunate, there's an IT system that supports cancer services. It's called Mosaic, and it flags the timing of producing these letters so that we could quite easily extract a measure from dictation to approval of letters. It's not the ideal measure. It would be better to have dictation to transmission, and we're working on that. We think we will be able to extract that measure. But for now, we're working on getting down the time from dictation to approval, and that's our measure. And the final question you ask yourself is, well, what changes do we think will make a difference? What areas can we change that we think is going to improve? Now, when I've worked in places, usually around the lunch table, we sit around and think of ideas for change. And we haven't necessarily thought what we're trying to achieve, or even how we'll know whether the changes are improvement, because we know that all improvement involves change, but not all change is an improvement. So we used a couple of tools to do the improvement in this project. The first one is we processed map the process of producing a letter, and second of all, we use rapid improvement cycles, or PDSA cycles, to make improvements. The aim was to have letters within a week. How do we arrive at that aim? Well, we actually did a small survey of our local GPs. When we sent them treatment summaries from cancer services, we included a small survey asking them, how long from the consultation did you receive this letter, and did you think it was timely, amongst other things. And this is some of the results we got. So you can see across the bottom there, days. So if, for instance, the letter took more than 40 days, as you can see on the right-hand side, it was all red. They thought that wasn't timely, and I don't think anyone would think a letter about patient care that took more than 40 days to receive was timely. If, however, on the left, the letter took 7 days or less, everyone thought it was timely. And in between there was a variation of opinion. So we felt confident that if we could get a letter out within 7 days, really the vast majority of people would think that was timely, so we made that our aim. We got together an expert reference group, and this is important for improvement, to have all the right people in the room. So we actually had cancer admin people, we had an oncologist, we had the IT people who run Mosaic, we had a GP practice manager, people from the Medicare local, and we had myself as a GP. And we sat around the table and we processed map the process. We began with the consultation, we finished with the GP reading the letter, and we used post-it notes in between to try and record what it involved in producing those letters. And here's a picture of the process that we came up with. It's long and involved, and it's easy to be amused by. But it's important in this circumstance that we're in a non-judgmental environment, because people need to be willing to be honest about the processes that we're using. All human processes get unnecessarily complex and bureaucratic, and this one is. For instance, there were 4 different routes for doing transcription, and we didn't know which one was best or which one was worse. There were multiple times of checking and approving the letters, and then there was the process of folding them and putting them in envelopes and putting them in the post, all of which involved time and all of which slowed things down. So it was really great to have this group working on it and identifying what actually happened. So you can see the circle on the left is the consultation, the circle on the right is reading the letter, and in between is the complex and circuitous process that is used to produce the letters. So we then took that process map and we formed a micro team, a subgroup of that expert reference panel, consisting of admin people from cancer services and ourselves from the GP unit. And we've been meeting every 2 weeks now since July and working on that process map, basically redesigning it, taking out steps, testing bits of it to see which bits work and which bits don't, and redesigning it, trying to get that dictation to approval time down. And this is what we've achieved. So the process map, you can see this is a run chart of that measure that I mentioned to you under the 3 questions, and you can see the green line is the summary measure. The blue line is a sub-measure, it's dictation to transcription, and the red line is transcription to approval. And those two, the red and the blue added together, give the green line, which is the overall measure. The process map was made somewhere in March, and we didn't start formal improvement, you can see, till somewhere late July. But already the team had started making changes in June and July to start changing the way the letters were produced. We couldn't start earlier because the cancer services were moving offices, so they just didn't have the time or the headspace to think about improving this. But you can see that once we started going and once the micro team started getting together, we got that dictation to transcription time down from something like 28 days. We're now down to 5 days, and we actually have a couple more dots of the run chart, and we're maintaining it at about 5 days. And if we can produce those letters dictated to approved in 5 days, we know that they're going to get into the post and into the GP's hands really in about a week. So we feel like we're pretty happy that we're getting close to what we want to achieve with that measure. So, given that we've achieved that, we've set a couple more priorities. First of all, it's easy to do it in a project, or easier. It's much harder to make that sustainable and routine and part of normal business, and so that's what we're working on now. So we're going to document the new process that we've created, and then we're going to make the data a regular part or a regular KPI on the dashboard of the executive that runs cancer services. So that will become part of the way they work. They'll review it every month to make sure that their dictation to approval measure is down around where they want it, around about 5 days, and if it starts to creep up, they'll have to start thinking again what to do. And then we've also moved on, so we've really dealt with the whole left-hand side of that process map. We feel like we've done just about what we can. What we're going to do now is work on the right-hand side, which is the transmission part of getting the letters from Mosaic into the GP's hands. And we're going to look at digital transmission. And in fact, this is a major part of the project. We were always conscious that we wanted to get to the point of getting these letters out digitally. Of course, we needed to produce them in a timely way within the cancer services, or digital transmission wouldn't help that much. But now that we've got that down, we're really hopeful that we can get a lot of efficiencies by going to digital transmission. At present, they use mail. We considered fax, but there's all sorts of reasons why the LHD doesn't use fax. Security, expense, all sorts of reasons why fax is not used. So we're going to digital. It really is the agenda. Digital to GPs, but also digital from GPs back to the LHD and to all the sorts of referral partners that we use is going to be a key improvement in the primary care world and the healthcare world, and we want to be part of that. It is a rapidly evolving environment. Anyone who's worked in the environment knows that there's been various software solutions commissioned and even installed, not necessarily functioning. You'll know that New South Wales Health is really pushing hard on Health eNet, which is an exciting initiative linking up all New South Wales health services and providing a conduit to primary care services. So we want to be part of that as well. And it's great that this project is an excuse to begin that conversation with our partners. So the strategy is to look at how those letters get, first of all, from Mosaic to the Cerner system that the LHD uses, and then from the Cerner to GPs. There is an existing bespoke system they use, and then of course there are the GP software solutions, Argus and HealthLink, but really we think that Health eNet is probably the way to go, and we've now opened up conversation about that process. So that's really the story. The conclusion that I wanted to say is, first of all, that it's really key for cancer care with the growth of improvement in survivorship and the growth in numbers of people living with cancer long term, not to mention the financial constraint that health is under. It's important that general practice and cancer services work together to provide a linked up, joined up service for patients. And partnerships are required. So this project has been a great opportunity for those partnerships to begin to be established and really be worked on. It's much easier to have a partnership when you're all working on something than just sign a theoretical partnership and intention to work. So that's been a real positive of the project. It's clear that timely communication is necessary, and it was great attending the Cancer Innovations Conference today and seeing a presentation from Professor Tim Shaw from Sydney University, who looked at the priorities of all the groups involved in cancer care, and actually the top priority was communication of information from primary to secondary to tertiary care and back. Top priority. So we're working in the right area. We've demonstrated that it is possible to improve. It's another thing to sustain it, but we've certainly been able to make improvements using the very simple tools of quality improvement. So, thanks for listening, and I hope that's been useful, and you may wish to consider that in some of the work that you do in improving the health services. Thanks very much.